cerebellum, and then finally the spinal cord. Another section I did look at the area, the limbic area. That's very important to us psychiatrists. And also the area called hypothalamus, the corpus callosum, optic chiasma, hypothalamus. All these are very, very key in the way human beings function. But if you look at these hundreds of billions of cells, we can look at them as neurons. And under these neurons simply looking at it, we can see the nucleus connects to another neuron. And then this is the mode of passing messages, or what we call signals, from one neuron to another neuron. That's the next slide. So we can see how the messages, we can see the arrows, how they connect from one to the other. Now let's move to the next one. A brief description of the brain function. The frontal lobe, because I said earlier that the brain can be looked into frontal lobes, parietal lobes, temporal lobes. Functions have to do with interspeech, the voluntary movements, memory, coordinating neuronal responses to inputs from the rest of the central nervous system. So the frontal lobe is very key in this area, especially the first parietal lobes. That's the next one. Interpret and other tactile stimulations. It has to do with touch, temperature, pains, size, and shape of things. So the parietal lobes is very key in that area. That's the next slide. And then I'm seeing the introduction because of time. So I'll jump to temporal lobes. The temporal lobes, that's the next slide, has to do with the understanding of language, sound, and speech. It's also involved in emotions and memory. So we start having that in mind now, because that's the area we are going eventually, the memory. Occipital lobes too, yeah, that's situated towards the posterior end of the lobes. The major function is in understanding and interpretation of visual images. The occipital lobes it's connected with the eyes, and it helps us also in the understanding the meaning of the written word. But I want to look at an important area of the brain too. That's the area that is called the hippocampus. The hippocampus plays a significant role in encoding and retrieval of information. And we know that damage to the hippocampus, as seen in dementia, leads to retrograde amnesia, which is the inability to retain newly learned information. Now, the big question, what is dementia? That's the next slide. What is this problem that we call dementia? Dementia is a syndrome caused by the disease of the brain. So it's right for us to say that it's the disease of the brain, usually of a chronic or progressive in nature, in which there is disturbance of multiple higher cortical functions, higher brain center functions, including memory, thinking, orientation, comprehension, judgment. That's the definition by the World Health Organization, National Institute of Aging, as a syndrome which refers to progressive decline in intellectual functioning, severe enough to interfere with person's normal daily activities. And so we can say that, oh, it's a neurodegenerative, not just one. And there are only a few types of dementia that can be reversible, like we'll talk about it very soon. But worldwide, around 50 new cases every year. It's a problem. Dementia is prevalent worldwide, though often misdiagnosed. This part of the world is often misdiagnosed. The lay people diagnose it as, oh, this person is this elderly person is a witch. It's a witch or it's a wizard, prevalent here. But even in hospitals, it's concerned, and that's why we are talking about it today. As I said earlier, around 50 million people have dementia worldwide. And it's one of the major causes of disability in later life. Everybody wants to grow up and live a comfortable life, retired into a life of peace and serenity. But unfortunately, dementia is a major causes of disability in those age group. 58% of all people with dementia worldwide live in low and middle income countries. It's frightening that by the year 2030, approximately 75 million people will be living with dementia because a lot of people are growing older now. The infectious diseases are being taken care of. So a lot of people are living up to old age now. In developed countries, especially Sweden and some other countries like that, the lifespan of people there is on the rise, even in developing countries too. So we are going to have more and more number of people coming down with dementia later on in life. By year 2050, that number will rise to 132 million. That's frightening. Well, what is not dementia? Next slide. A lot of people, as I said earlier, they misdiagnose this. The dementia is not the same thing as depression. Though depression may harass the onset of dementia, there's a clinical presentation in depression that mimics dementia. We call it pseudo-dementia. Pseudo means false. It's a common feature of dementia that when you talk to an individual who is suffering from depression, say, no, I can't remember things. I can't remember. I can't remember. It's not making effort to even remember. It's born out of the clinical features of depression. But pseudo-dementia is not the same thing as dementia. Another one is delirium. Delirium is there's clouding or fluctuation in the level of consciousness, usually active in nation and often due to metabolic disorders or acute infection in the body system. Metabolic disorder like thyroid functions, like thyroid disorders like diabetes, other metabolic derangement in the body can make an individual to have delirium. And in delirious state, some people can misdiagnose that as dementia. No. But we should also understand that an individual having dementia can also have some other medical problems and may also have delirium. So sometimes delirium can occur to an individual suffering from dementia, but definitely it's not the same thing. Yeah, the third one that I just want to emphasize on this slide is that forgetfulness associated with normal aging is not the same thing as dementia. All of us, we do forget things one way or the other. And as you grow older, yes, it can be part of normal aging. But the difference is that the normal forgetfulness during normal aging should not interfere with normal daily function and should not cause disability for the individual. Unlike dementia, that's, yes, the daily function will eventually be affected and the person will not be able to function well. If you look at the broad symptoms of dementia, so you can now see from these broad symptoms why neurologists and the psychiatrists play their own role in the management of dementia, because some of the patients will present to neurologists and some will present to us. It depends on the cluster of symptoms that you see in them. The symptoms, let's just look at it from this layman's angle of cognition, behavior, and emotion, right? So the cognition has to do with memory, learning, especially new things. The language will eventually be affected, slowed down, and later incomprehensible. You can't hear what they say again, mumbled up things. Their judgment will be affected. We need our higher center to have good sense of judgment. And there will be lots of abstract thinking or reasoning among those people who suffer from that. But when you see their behavioral symptoms, there's change in behavior, there's impaired communication, and then there's issue of safety because the person may wander away from home. The personal care deteriorates and there can be disruptive behavior. The person may easily lose assets or money and start wandering away. And of course, later on, hallucinations and delusions, which are hallmark of psychosis, may come in. And they may make false accusation, and that's very common with them. Elderly woman that misplaced her purse and start accusing the grandchild of that you have stolen the money. And eventually, grandma will find the purse where she kept it, but where she had forgotten it. So they can make a lot of false accusations. These are behavioral symptoms. We classify them. And of course, there can be emotions, symptoms that have to do with their emotions. They can become depressed, they can have liability of moods, the fluctuation of moods. They can become intolerant of people. Elderly woman that has been fond of the grandchildren now becomes intolerant of them, can become disorganized and confused. Of course, with time, they have apathy, loss of energy, loss of willingness. So when we see this cluster of symptoms, depending on which one starts first, behavioral, the emotional one, they think this is a psychiatric thing, so they see psychiatrists. But if it's more of cognition, they are most likely going to see a neurologist. But by and large, we both, this is a multidisciplinary area that psychiatrists have their own role, neurologists have their own roles. Let's look at the dementias now, the different types of dementia based on the causes of dementia. Alzheimer's disease is the commonest, accounts for about 70% of dementias, followed by vascular dementia, 20%. Then the rest will account for the remaining 10%. Lewy body dementias, Huntington's disease, Parkinson's disease, frontotemporal dementia like Pick's disease, Creutzfeldt-Jakob disease, variant of it seen in mad cow disease. Also, these are rare forms of dementia, causes of dementia. Of course, AIDS, acquired immune deficiency syndrome, can later on lead to dementia complex too. It's a form of subcortical dementia. I talked earlier about a little fragment of the dementias that can be reversible. That's normal pressure hydrocephalus. Normal pressure hydrocephalus can be managed, and the dementia can be reversed largely. Here we have syndromes of dementia, urinary incontinence, and gait disturbance. Of course, there's this hydrocephalus, but the CSF is normal in this case. So that's normal pressure hydrocephalus. And then punch-drunk syndrome and many other rare conditions. Punch-drunk syndrome in those who have absorbed a lot of punches from boxing profession. Some of them may later on in their old age suffer from punch-drunk syndrome, a form of dementia. The differential diagnosis in dementia, also, I look at some aspects earlier, but also let's lay emphasis on them again. Structural brain lesion, especially subdural bleed. People can also misdiagnose that as dementia. Also, thyroid disease, vitamin B12 deficiency, yes, can also be a form of, can mimic dementia, but not exactly dementia. Alcoholism too, yes. Wernicke's encephalopathy and Korsakoff psychosis can be follow-up of alcoholism in some individuals, and they may have some form of forgetfulness, memory issues. So alcoholism, serious one, later on, can be a differential diagnosis. And I said earlier, depression or anxiety, people are anxious, people are depressed, they have pseudodementia. Then medications like benzodiazepines, opioids, anticholinergics, first generation antipsychotics, dopaminergics, this also can mimic dementia, because patients taking those medications may later start complaining that they forget things here and there. But that's not the same thing as dementia. Now let's look at Alzheimer's dementia proper. Next slide. Alzheimer's disease came into being when Alois Alzheimer made a diagnosis in a patient I saw in 1907 Alzheimer happens to be a professor of psychology then. And he described the case of a 51-year-old Mrs. Auguste Dieter and subsequent pathological findings that were found in this patient, like neuronal loss, plaques, and tangles were found during the autopsy. And then that's how the disease was named after Alzheimer. And we can see from this picture that the people who suffer from this, over 80% of patients suffer from these are people who are 75 years and above. It's very rare to find dementia in those who are less than 65 years, but we tend to look closely at this diagnosis of dementia in patients who are 60 or 65 years and above. But it's very rare to find this among those who are less than 65 years old. When you find them like that, maybe due to vascular dementia. I've seen patients with vascular dementia in his 40s, background history of hypertension and all that, and then later on start having vascular dementia, but it's very rare. So majority of patients who suffer from this are those who are elderly, the senior citizens. So Alzheimer's disease, next slide, is the commonest type of the dementias. As I said earlier, accounts for about 70% of cases or more. It's a progressive, degenerative, irreversible dementia. Let's take note of that. It's a progressive, degenerative, and irreversible form of dementia. The prevalence rate for AD is about 7% in United States for individuals aged 65 or more. And the risk all over the world doubles every 5 years after the age of 65. So every 5 years, the risk doubles. In America, the Black race and people from Asian origin also tends to come down with Alzheimer's disease than the Hispanics themselves. The pathology seen there, the presence of senile plaques and neurofibrillary tangles in the brain. That's during autopsy. But there are two types, clinical types also, the sporadic one and the familiar autosomal dominant Alzheimer's disease. The sporadic one, and then next slide, this makes up to 90% of cases. And people with this form may or may not have a family history of the disease. The offsprings of people with sporadic Alzheimer's disease have higher risk of developing Alzheimer's disease when compared to people with no family history of the disease. So yes, the issue of family history is very key here too, but the majority of cases, 90% of cases are the sporadic Alzheimer's. Then the FAD, familial autosomal dominant Alzheimer's disease. This is relatively rare and makes up about 10% of all cases of Alzheimer's disease. The genetic vulnerability here is very high compared with the other type, the first one, the sporadic one. Here, there's identification of amyloid precursor protein, APP, and presenilin genes 1 and 2. And mutations in these genes have been theorized as the leading cause to early onset of FAD. The loci of the genes where these were found was on chromosomes 21 and 19. So we can now see the relationship between Down syndrome and Alzheimer's disease, because the loci where this abnormality were found was also on that chromosome 21 and 19. FAD is passed from generation to generation due to a dominant inheritance pattern. So if a parent has the mutated gene, each child has a 50% chance of inheriting it. Let's look at 7 early signs of Alzheimer's disease. Let me rush over this because we still have a lot to talk about. The National Institute of Aging in America posted 7 early warnings of possible development of ADs. When you see people asking the same question over and over again, they should be watchful. We are talking about prevention now. Or constantly repeating the same story, word for word. They need to watch out. Forgetting activities that were routine, such as cooking or playing cards, when not that you are busy on social media on your phone and your food got burnt. But if it becomes a regular thing, then one needs to really watch out. Losing one's ability to manage critical activities, such as managing one's finances and paying the bills, can also be a early warning signs. Getting lost in familiar surroundings or misplacing household objects. Misplacing household objects. You don't know where you have dropped the TV remotes. Every now and then you look for it here and there. You better wash out and do something on time to avoid becoming an invalid. Neglecting personal hygiene while insisting that they were clean can also be a serious warning sign. And relying on someone else to decide and respond on issues they normally handled themselves. But in this case, we have to be sure the person is not having anxiety disorders or depression. Let's talk about risk factors for Alzheimer's disease. Advancing age, as I talked about earlier. So those 60, 65, lucky enough to live up to 70, 85, the older you get, then the more the risk, the chances are high. People also have a mild cognitive impairment. We'll talk about that very soon. It can be a risk factor of Alzheimer's disease later on. Of course, family history of Alzheimer's disease, genetic issues like ApoE4, low education levels, head injury, cardiovascular problems. Even Alzheimer's disease, yes, cardiovascular problems can also be a risk factor. Down syndrome, as I mentioned earlier, sleep disturbances. Let me talk about this one because we have to lay emphasis on prevention. If we say this problem is potentially irreversible. Sleep disturbances. We need sleep for 4 things in our lives. That's why children, they sleep much more than adults. But even adults, we still need up to about 6 to 8 hours of sleep in 24 hours. We need sleep for growth. We need sleep for memory. We need sleep for our neuronal regeneration, for our neurons to regenerate, to kind of restarting, rebooting. So during sleep, that's when all those things happen. So we need sleep also to adapt. That's why when people find themselves in an environment or they have a sleep jet syndrome, they find it difficult to get themselves up again when they're in another climb with time difference. So sleep helps us a lot, especially in the area of memory. You want your memory to be okay, please take time and sleep. Environmental factors also have been implicated. High metals in some areas have been considered as also possible risk factors. Let's look at major hypotheses for Alzheimer's disease. I talked about the beta amyloid protein earlier. There are two groups here, hypotheses here, the Baptists and the Taoists. The Baptists, here we talk about the accumulation of a fragment of the amyloid precursor protein, or APP, the amyloid beta residue fragment of AB42. This can lead to the formation of plaques that can kill the neurons. We are going to look at the few slides, and then it becomes clearer to us. And then those who believe there is an abnormal phosphorylation of tau proteins, normal proteins in the brain. So they become sticky, leading to the breaking up of microtubules, and the resulting loss of axonal transport causes cell death. Let's look at the picture, the tau proteins. Yes, we can see the picture here. Let's move the slide to where we see the amyloid precursor protein. Yes, good. Here, the amyloid precursor protein here is the precursor to amyloid plaques. So we can see the cell membrane, we can see the APP molecule. So when they break down like that, they stick through the neuronal membrane, and this causes a lot of problems. The enzymes called the APP in the brain into fragments of protein called beta amyloid. So accumulation of these beta amyloid fragments come together in clumps from that third picture to form plaques. And then when we look at the cell, there's the next slide. You can see the normal cells and the Alzheimer's cells. Next slide. Yes. So we can see that the area of the neurofibrillary tangles, how they have accumulated, and then down And that's Alzheimer's. You can see the amyloid plaques. The accumulation of these eventually leads to neuronal loss, neuronal deaths. Looking at the sagittal section, the section of the brain, you can see the healthy brain and the Alzheimer's brain. The ventricles in Alzheimer's brain are much enlarged because the neurons have been destroyed, so to say. The gap in between the gyros, we can see it's called sulcus. It's much wider now compared with the normal brain. And all these structural issues we see here eventually will affect language, will affect memory, and many more things. Earlier, I talked about mild cognitive impairment. The next two slides, let's look at this, mild cognitive impairment. This is what is usually seen. Next one, before the next slide, yes. MCI is a relatively recent term used to describe people who have some problems. Let's take note of that, some problems with their memory, but do not actually have dementia. So they do not measure up to the diagnostic criteria according to the DSM-4. So, well, the patient is not normal, but we cannot also say that they are demented. There's evidence of cognitive deterioration for age. They tend to have problems with their memory, but they are still able to perform their daily living activities. Those activities are still preserved. And if at all there's some changes, it's minimal, minimal. So the question here, should we start treating them at this stage or not, is debatable. A lot of people don't agree that we should start treating people with mild cognitive impairment. That sometimes a lot of them may not descend to dementia, but we also know that some can go into dementia. In this part, in our clinic, when we see people with mild cognitive impairment, we might need to give them some things to help their memory enhancer, so to say, or in some cases, when we present to the patients, if they feel that we should start managing them at that stage, or their relatives feel that we should start treatment to some extent, we usually do that. Let's look at the clinical symptoms. Mild stage of Alzheimer's disease. What are the things we see there? The memory loss continue. That's the next slide. Okay, this slide. As memory loss continues, the victim may often is often dismissed as normal aging. It's passed on that, oh, it's part of aging, it's part of aging. But later on, they have problem talking properly. They increasingly get confused in their familiar environments. They have trouble handling money and paying bills. As I said earlier, I repeat questions a lot, same questions. Taking longer time before to complete normal daily tasks. Yes, that's what we also see in them. And eventually they start having poor judgment and start losing things or misplacing them in odd places. There can be mood or personality changes, but it's to be mild at this stage. Moderate stage, next slide. There's increased memory loss and confusion. There's problem recognizing family and friends. Sometimes they want to call the first child, they mention the name of the third child. They start interchanging names like that for family members, Then they find it difficult to learn new things. They have difficulty carrying out tasks that involve multiple steps, such as getting dressed. They get confused along the line. They have problems coping with new situations. And then gradually the stage of BPSD arrives. These behavioral and psychological symptoms of dementia. And key to these symptoms are more of anxiety and depression, more of psychosis, delusions and paranoia, and impulsive behavior. An elderly man just pounced at a 5-year-old or 10-year-old and wants to rape, or a judge or a retired judge goes to the mall, supermarket, and starts stealing things that are worthless, or let me say, that does not worth anything significant. Someone who knows the implication of that, not someone who's financially buoyant enough, but will just go to Spa, or let's say ShopRite locally here, and go and steal things that probably is not even up to 500 naira. So for someone at that stage, such kind of impulsive behavior can happen. And sometimes they can be aggressive too, without any reason. Impulsive behavior can happen. These are some of the symptoms of BPSD, behavioral and psychological symptoms of dementia. In advanced stage, there's total dependence on others. That's very serious. The person is practically unable to fend to take care of himself. May not even be able to recognize himself or herself or family members. In advanced stage, they find it difficult to communicate at all. They mumble words, they grumble, but you can't even hear what they say. There's weight loss, and this is often due to poor appetites. They can have enuresis, defecating on themselves. I remember a particular man like that, a well-educated person who will be defecating on the wife's laptop on the bed, Or sometimes they take fecal matters and rub it on in their rooms, on the wall, That can be very, very challenging for their caregivers. Then they have skin infections because of the immunity that has gone down. They are not eating well. They have difficulty swallowing. As I said earlier, they groan, moan, or grunt. At this stage, they spend most of their time sleeping a lot of the time. As I said earlier, there's lack of control of bowel and bladder. When you put them on pampers, they even want to remove it, and then it's so difficult to manage. Death is often as a result of aspiration pneumonitis when they cannot swallow very well. So respiratory infections, usually the major cause of death. Let's quickly look at the other areas of dementia. I will rush through this. Vascular dementia. This one, they have a stepwise deterioration. That is, the person suddenly gets worse. It's okay for a while. They suddenly have a dip again. So stepwise deterioration. They may or may not have symptoms of stroke, but usually there's a background history of multi-infarcts, ischemic changes in the brain. I saw one recently, and when we did a CT scan, we could see areas of multi-infarcts, ischemic changes. It was a known hypertensive, and now you find it difficult to remember things. Memory issue is there now. So there's the control of blood pressure, cholesterol, and diabetes, stopping smoking, exercise, and other lifestyle changes are important preventive measures here. Please, let's take note of that, and advise ourselves and also our patients. There's need for them to control their blood pressure, their cholesterol, and control their diabetes, stop smoking and exercise, and adopt lifestyle changes that are very germane for keeping away from vascular dementia. Lewy body dementia, this is related to both Alzheimer's dementia and Parkinson's disease. Oh, let me say this earlier. Alzheimer's dementia patients can also have vascular issues. So sometimes you can have a kind of mixed dementia, background history of vascular and also Alzheimer's. Now, Lewy body dementia is similar to Alzheimer's dementia, except that there's more day-to-day fluctuation. There's more hallucinations in this group, especially visual hallucination. And use of antipsychotics can worsen this condition if care is not taken. They have Parkinson-like symptoms like tremors, muscle rigidity, slowness of movements, shuffling gait too. That's Lewy body. Frontotemporal dementia is also called Pick's disease. That's next slide. It often starts with behavioral change, much more early than memory loss. So the difference between this and Alzheimer's is that the behavioral changes tends to occur much earlier than we see in these patients. There's mood changes. These are common too, compared with Alzheimer's dementia. Mood changes are very common here too. Behavior are quite common. The disorder is characterized pathologically by age aerophilic inclusion bodies within the cytoplasm of cells of the frontotemporal cortex. Please, are you still with me? Can you hear me? Hello?
Yes, we can. We can hear you, sir.
All right,
I hear you, sir.
All right, sir. Because of, so in making our diagnostic approach, So we look at the various forms and then we'll know what to do, whether dementia is with neurological signs or systemic illness. If it's like that, we'll think of Alzheimer's disease or Pick's disease. What are the investigations we'll do? CT scan, MRI scan. How do we confirm the disease? Is usually during pathology, when during postmortem. We cannot be removing the brain tissues while the person is alive. Pathologists usually do that post-mortem. If there are neurological signs like gait disturbance and incontinence, as I said earlier, we also think of normal pressure, hydrocephalus, frontal lobe tumors, Huntington's chorea. So you can see, by and large, most of these patients will need to do either CT scan or MRI. We are thinking of vascular dementia, we would like to do more of CT scan. But if we think of Alzheimer's, MRI, magnetic resonance imaging is preferred in this case. But we are thinking of infective disease like HIV, AIDS, syphilis, meningitis. Yeah, would like to do a lot of other tests, serum antibodies and other HIV status, CSF examination. These are various forms of investigations we can do. Let me just jump to the management. As I've talked about earlier, it's a multidisciplinary team approach. The people that have a lot to do here, nursing care planners, because oftentimes we don't get the patients at the mild or moderate stage. Sometimes it's moderate to severe stages we see them. As I said earlier, there's a problem of misdiagnosis or passing the buck as normal aging. So oftentimes in this part of the world, we see them as advanced stages. So the nursing care planners, nursing staffs, they have a lot of work to do. I also talked earlier that neurologists, they also play their own roles here. So also cardiologists who have been managing patients earlier with cardiovascular issues. Later on, they discovered their patients are having memory issues. So they refer the patient either to see neurologists or see psychiatrists. Endocrinologists also have a role to play. Pharmacists have a lot of role to play, which I will talk about later. Clinical psychologists, social skill trainers, occupational therapy. These are very, very, very key. Occupational therapy in helping the patients in the area of activities of daily living, ADL, very, very key. And social work involvement is also important. So social workers. So we can say a lot of specialists have roles to play in this, not just doctors alone. Everybody's role here is acknowledged as very important, very, very important in managing this patient. Pharmacological treatment, the medications for Alzheimer's disease can be in the varieties, cholinesterase inhibitors and NMDA receptor antagonists. That is N-methyl aspartate receptor antagonists. So for cholinesterase inhibitors, we have the Pesi, galantamine, rivastigmine. We usually prescribe this for mild to moderate stages of Alzheimer's disease. When we are thinking of moderate to severe, we would like to go for memantine, which is another class, different from cholinesterase inhibitors. And the dosage is tailored after individual patients, as you see in that this table. I would like to lay more emphasis on lifestyles and dementia. That's the next slide. Causes of dementia are complex and multifactorial. We know that environmental factors which are precipitating or perpetuating can at least be modified to a large extent. Lifestyles issues can be modified to a large extent. Positive life measures, which we'll talk about very soon. The many negative ones are capable of lowering the threshold to dementia. So we need to be aware of that. How do we prevent or slow down Alzheimer's disease chances? Antihypertensive therapy is very key. So when we are, as pharmacists, when we are seeing our patients who are on those medications, please let's continue to do what we call psychoeducation in mental health. Psychoeducation is not just limited to doctors, psychiatrists or nurses. Pharmacists here in the place where I work, they are very superb. Pharmacists at Federal Neuropsychiatric Hospital, Yaba here, they do psychoeducation of patients a lot. They advise our patients. Kudos to my people here. And I believe that should also be what obtains in other places. It's not just dispensing medications. They take time to also emphasize the importance of this to their patients, that they should use these medicines more rather than take the painkillers alone, but they should lay emphasis on the antihypertensive therapy, not missing it here and there, taking it regularly, religiously, persistently, and not skipping it here and there. Non-steroidal anti-inflammatory drugs, antiplatelet aggregants, some people believe can also help. Yes, vasopressin, things that can help the process in the vessels to ensure that patients don't come down with stroke. It's also very key. There's increasing awareness about lifestyle, about food, about fish oil, especially omega-3 fatty acid. This is becoming more emphasized nowadays, both for prevention and slowing down Alzheimer's disease chances. Omega-3 fatty acids, a lot of people now believe that can play a very good role, big role in helping the patients from coming down with it or slowing down. Weight control, moderate exercise is very key. Healthy diet is very key. I mentioned earlier adequate and sound sleep. We can't overemphasize this. Vitamin B's, mineral supplementation is also key. Some people have tried hormonal agents, but it's debatable. Meditation and spiritual activities for elderly people, not sitting down at home, but being involved in community work, volunteer work, activities, being involved in their CDAs and all that, even just to go there and gist and talk to their colleagues. All these activities outside home, very key for people to prevent or slow down the AD. Then there's crucial roles of us health practitioners. That's the next slide. You and I, we need to know that there's need for more education and awareness on dementia. We need to demystify the notions people have about it, that elderly people, when they are behaving one kind in quotes, that maybe they are witches or wizards. A lot of them have been lynched. A lot of them have been banished to isolation. A lot of them have been deprived just because people do not have the proper education and awareness on dementia. Dementia is a worldwide thing. It's not just limited to Nigeria or the Black race. It's all over the world. It affects people in so many countries. There's no country that is left behind. So we health workers need to do more, not just during the Alzheimer's month like this. It should be a regular thing. We need to create more awareness. We are the one who will do this. We should not expect economists or agriculturists to be the one that will do this. We are the one. But even we, the health workers, we need to show respect and empathy for those having Alzheimer's disease. We need to be patient with them. When they come to our clinic, when they come to our hospitals, when they come to our environment, we need to have respect for them and show empathy for them. Remember, nobody knows what can happen to him or her tomorrow in old age. We need to acknowledge the burden of care and the caregivers, those who are managing these people are passing through. A lot of them will eventually come down with depression. Yes, a lot of the caregivers. I know a particular man that will be managing for dementia. The wife had come down with depression now because of the magnitude of what she has to do, caring for her husband 24/7. So we need to acknowledge the burden of care these people pass through, the caregivers, and support them too. So sometimes when they come to the outpatient pharmacy department and they are irritable and wherever, I mean the caregivers, it is because they are just trying to act out. They are just trying to dissipate the bottle up frustrations on others, not deliberately sometimes, Then we also need to play a major role in advocacy for positive policy support, both for the victims and their caregivers. Yes, a lot of people are doing a lot of advocacy for HIV, for malaria and all that. Good, but we also need to pay emphasis on people suffering from dementia too. What can we do about our national health insurance that will support the pharmacotherapy, because these medications are rare, are scarce, and oftentimes not affordable. Is there any way we can put pressure on any NHIS to put these deep medications in their list so that people who are enrolled on NHIs can benefit from this, especially these hapless elderly citizens who seems as they don't have voices again, to clamor for help. We can be their mouths, We can be of assistance in this area, put pressure on NHIs so that these medications will be in their list. Then pharmaceutical organizations like yours, pharmaceutical companies, they have a role to play in the availability and affordability of these very crucial, relevant medications. Yes, even if the medications cannot reverse it, but it can slow down the rate at which the patient goes down. So give these people some quality of life that they actually deserve, please. A lot of our patients cannot find these medications. A lot of our patients, when they even manage to get them, they are not affordable. If people find it difficult to get in Lagos here, how would they now be able to get it in my native Ekiti or your native Ebonyi or the Osun states or Kwara? It may be very difficult. And we have dementia patients too in these areas. Well, let's move on. Some people believe that there's a kind of diet called MIND. The MIND diet. It's also called Mediterranean diets. Next slide. Mediterranean diets was also said to be very, very helpful. Next slide, please. Green leafy vegetables, fruits, moderate amounts of fish, low to moderate dairy products, very limited red meats. Next slide, please. Very limited red meats. Use of olive oil instead of butter or margarine. Nuts, such as walnuts, avocado, are said to also be very, very crucial. I'm not sure whether my people are still with me. Hello? Hello? Can you hear me, please?
Loud and clear, sir. We are with you.
My next slide is not following, please. Please assist me.
Okay.
I talk about Mediterranean diets or MIND diets. Okay. Yeah. Okay. If we can't have that slide, let's look at the pictures here. At least maybe the message would be passed better. Are you having my slides again?
I think Ebenezer dropped off. I'm sure he'll soon be back, but we can continue.
All right, sir.
He lost connection, yes.
Yes. Lifestyle changes, exercise outside home, not just indoor alone, but indoor is also good. So we should encourage elderly people to do exercise outside home. Gentle one, moderate one, not severe one. And not, we don't encourage elderly people to exercise on their own. They should do it in groups or with have people around them so that they don't come down with any serious exhaustion. And if anyone that is exhausted, that someone can assist. We should encourage people to stop smoking if they smoke. It's better to stop smoking. And well, this is debatable. Some people believe that red wine can be of assistance, but it's quite debatable. So we need to be very careful. Now, let me talk about this. Before the plaques and the taus take over the brain, the family is key. Your family is key. Connect well with your loved ones, your friends, your neighbor, and your community. Don't be a loner. Connect well with them so that in your old age, you don't live in isolation. Remember, there is what we call the emptiness syndrome. When you have retired, your children are in Paris, they're in London, they're in Dubai. They are fending for themselves there. So you are the only one left in that duplex. And Madam has gone to do Omugo in so many places. So the elderly man has suddenly become a bachelor, living in a 4-bedroom, 5-bedroom duplex or mansion. So becoming a loner there is not good. So let's move the slides. Let's move the slides now. Let's move the slides. So all these are very key. Green leafy vegetables. Yes. Go on, please. Yeah, this where before the plaques and towels, those are the things we see in the brain. Before they take over, your family is key. So you may also need to consider a good health insurance coverage to take care of you in your old age. You need to prepare your will before dementia sets in, so that people will not start fighting that over that in future, that you are already demented when you put up your when you did your will. So you might need to prepare your will before dementia sets in. It doesn't mean that one wants to die, no, but you need to prepare for that age, especially if you have family history of dementia anyway. Carefully identify who you give the power of attorney to. Peradventure, dementia now sets in and you cannot do much for yourself again. Who has the power of attorney? Consider that carefully. Somebody who can be able to take care of you. Hopefully, prayerfully, I hope so. We have challenges in management of dementia. Arriving at diagnosis, comorbidity, hospital visits, hospitalization, treatment issues. All these areas, follow-up of patients, burden of care, my, family, finance, frictions. There are lots of challenges in the management of dementia in this part of the world. Even the clinical diagnosis, when you want to do CT scan, MRI, how many of our patients can afford this? How many of these elderly people that needs to be held at hand as if they are toddlers can be coming to hospital regularly? That's another issue. Oftentimes they have comorbid conditions, orthopedic issues, sight issues that limit their ability to even move around. These are issues that we need to consider. And the treatment issues itself. Even the medication, we have to be very careful how we load them with either antidepressants or antipsychotics in some cases to be sure that they don't develop serious side effects. These are challenges in this part of the world that we have. Let me jump to the area of hospitalization where we have them here. Most of our facilities here are not unique for elderly ones, but we have a place in Ibadan now, opposite UCH, a place donated by the late Tony Aneni that takes care of the elderly ones. So that's a multidisciplinary center that an elderly person can come in to take care of their high blood pressure, their diabetes, and at the same time, see specialists who can handle their dementia or other problems they have. So like a one-stop shop. That would be an ideal thing for us to replicate in other parts of the world. Why can't we have such in Lagos, in Akure? Why can't we have it in Owerri? Why can't we have it in Asaba and other places too, to take care of our elderly ones so that they don't suffer? And when they are on the hospital, our facilities even suitable for them, our toilets, our beds, the beddings. Do we even have wheelchairs to take care of this group of people? These are some of the issues we have. Many of our hospital caregivers have no training in handling elderly patients too. And of course, we usually see elder abuse, even among health workers. Don't let me talk so much about that. It's very, very annoying, very, very, very sad, and very embarrassing. Challenges of treatment again. There's no government policy on the care of the elderly ones. Oftentimes we have sporadic concern in some quarters. We hear of some politicians putting night glasses on the elderly ones. What of their dementia? What of their blood pressure? Just because some people want to be in the news, for political reasons. But we need to turn this to real policy, not just haphazard thing. What of the cost of investigations that are quite high for elderly ones? Treatment should be free or at least subsidized for elderly people who suffer from this disorder. I put it in capital. Please, this is my desire, this is my prayer, that treatment should be free. We, the younger generation, should do this because we are also going to discover tomorrow that we are in that age group as senior citizens. So let's prepare well. Let's make that old age, that's age conducive for people to live in. That's what happens in developed world. Medication for AD is often unavailable or affordable or unaffordable. I've mentioned that over and over. I keep on talking about it. We need to do something about this. Physiotherapists, orthopedic treatment costs, these are part of the challenges they bear or their caregivers bear. The next slide. Who look after the patient thereafter and ensuring proper care? These are the caregivers. There's a lot of burden on them. Caregivers are liable to develop burnout syndrome. They are likely to develop depression and emotional problems, including frustration. And this can invariably lead to neglect of these patients, the isolation of this patient, or elderly abuse, which can be physical, psychological, sexual, and economical. And that's why the tendency nowadays is home care or care home. And we need a lot of people to go into this area to have home care services or the care home. Either we develop, either we deliver the services to them at their homes, or we have a center where they can be taken care of. I know a center like that in America, where you can bring in the elderly ones, like a daycare center. You bring them in the morning, and then in the evening, when you are coming from work, you drive in and you take your elderly patient home again. So you don't leave them at home watching TV or barricaded by the iron crossbars in your home, and they are just wasting away there. Areas that we also need to pay attention on. By adventure, you have an elderly one with dementia. When the activities of daily living is very key. What I mean by that, toileting, bathing, dressing, eating and swallowing, sleeping, leisure. If you're having issues in this area, you might need to get a nurse to do that at home, or a occupational therapist who can also help these patients in managing these very key areas. Attitude of us caregivers. There's need for training, registration, and regulation of our practice to ensure professionalism and protect the interests of the patient. So even these sporadic nursing caregivers that are coming in Lagos now, there's need to regulate their practice so that it will not be like another like baby factories where people are doing something else. So we don't want elderly people to be abused. In these centers, there must be some level of professionalism, some level of control, some level of policy that will control their practice. There's medical legal considerations, including power of attorney for the care, so that the caregivers don't abuse them. And the mode of communication is also very key. As I'm rounding up, I want to look at the role of NGOs in dementia. Let's, because of time, role of NGOs in dementias. As often said, governments alone can't solve all the health problems. So there's need for us to aggregate together, not as neurofibrillary tangles in the brain, but positive aggregation to set up NGOs to assist the elderly ones. There's need for us to be mindful of the mission and the vision that should be clearly spelled out in such. And we must be properly registered to do such. Government should have regulatory board to license and oversee the activities. You must train your staff. It's mandatory. And then there must be synergy. You must work with other agencies. Don't work in isolation. Before I talk about my conclusion now, there's this Netherlands model that started in 1993. In Netherlands, they have a very good program for their elderly ones. They have good nursing homes, that takes care of these patients who have Alzheimer's or dementia. You can look at the picture. There's a picture of Dementia village in Hogeweg. It's very close to Amsterdam. Can we look at the picture there? We can see a very beautiful setting that people can bring in their patients to. And the environment's very conducive. There are people who can take care of them. There are shopping malls that is unique for them, and that they can go into. Can we look at that picture? Can we look at it? Next slide. As I'm rounding up, yes, you can see it. This that's the Alzheimer's the village near Amsterdam, Dementia village. Next slide, you can see the clean environments, good support that these people have. Next slide. Next slide. Next slide. Okay, now I go to recommendations now. There's need to pay serious attention to the health of our elderly. There's needs for us to incorporate the interests of the elderly into the planning, organization, and execution of our health policy. As I said earlier, treatments for dementia should be free. If at all not, government cannot do that, it should be highly subsidized. Our NGOs should have interest in the well-being of the elderly and should be professional in their activities. NGOs should partner with the existing health agencies for optimal outputs. As I conclude, now, the well-being of our senior citizens should be a concern to all of us, you and myself. The youth of today will be the old people of tomorrow, no doubt. A nation having no regard for a senior citizen cannot stand in the Committee of Responsible Nations. We all have important roles, especially those of us who are health workers, to play in helping ourselves. Remember, dementia has no respect for anyone. We don't know who is going to be the next to be added to the statistics of dementia. I don't pray it to be you. I don't pray it to be mine and myself, but we don't know anybody. Dementia has no respect for anyone. I thank you for listening to me. I would like to entertain questions at the right time. Thank you so much. Thank you for this opportunity.
Oh, what an awesome presentation, sir. Wow, that was deep. Thank you very much for this illuminating presentation. And I trust that the questions, we already have about 4 questions. For those of us on this webinar, please put in all your questions in the question area, not in the comment section. All your questions around memory loss, Alzheimer, dementia, whatever it is. It's not every day we have a super sound psychiatrist working with us, like we have Dr. Adebayo this morning. So let's send in our questions into the question section. I will want to invite Ebenezer Olayinka from New Heights Pharmaceuticals to make his presentation, while Pharmacist Folashade Lawal will be on standby for her session. So Ebenezer, over to you. Let's take it away from here. Dr. Adebayo spoke about the role of omega-3 fatty acids, and that's what New Heights is bringing on the table today. Ebenezer, take it away from here.
Yes, thank you very much, sir. Good morning, good afternoon now by my time, everyone. I believe you can hear me. Mr. Shino, can you hear me?
I can hear you, sir, loud and clear.
Great. And listening to Dr. Adebayo, I think I picked a better topic for myself, talking about maintaining brain performance at 40 plus, because looking at the bodies that happen when dementia sets in, the only way, which is what Dr. Adebayo ended with, is for us to pray and to also take precautions not to be added to that number, because sincerely, the numbers can be scary. Now, especially looking at the burden, both the financial burden and also on the family members around you. So I just want to say, I think for me, from 40 plus, we need to take in things, precautions as being prescribed, from eating well and all that, and exercises and vitamins, in order for us to slow down dementia. That is just the key message here. Now, looking at my slide, the first thing is that, Dr. Adebayo have said all of this, aging is not avoidable. All of us pray to get age, but the truth is that it is not compulsory that because we are getting age that our brain must also get so aged or end up with dementia. And looking at it, I looked out because, like I said, it is not a good thing to manage the burden. And like, I know I'm not going to spend much time here, as Dr. Adebayo talked about how memory loss can be either temporal or permanent, how it moves to Alzheimer's, things that can lead to that and all that. I'm learning mine from it. Now, but there's something I want us to see, that research has proven that there are some certain vitamins that help to slow down the brain getting into dementia. And one of these, as Dr. Adebayo rightly mentioned, he also mentioned it in his presentation, talking about omega 3 plus. We talked about the vitamin B contribution and all of this in slowing down prevention and helping us against dementia. And that is exactly what we are bringing it on to you today. Now, let's quickly look at the omega 3 plus 6 or omega 3 that Dr. Adebayo have mentioned. Now, this omega 3 is one of which has DHA is the most abundant fatty acid in the brain and the central nervous system. Now, this is the most abundant fatty acid that you can see, and it is also found to have high concentration at the frontal lobes. Now, at the frontal lobes, if you remember, and the frontal lobes is where it's responsible for the memory, the language, the attention, as Dr. Adebayo has spelled out for us. So research have shown that omega 3 fatty acid is actually found to be in abundance at that rate. And studies have also shown that for people that have dementia, there is a decrease of DHA available in them. There is a decrease of this important fatty acid in the blood sample of people with dementia. Now, research has also shown there is an intervention trials that have been done that for people that have AD, that is Alzheimer disease, that there is a lot of benefit they get from DHA supplement. And don't forget what I said. For me, looking at the burden that have been mentioned and all of this burden, both on the government part, on the caregiver part, financial burden, it is very important for every one of us. For me, from age 40, to slow down you getting down with dementia, especially in this kind of environment. Now, from the research, it has shown that when you take DHA, especially for people above 40 years plus and all that, it helps to have increased cell membrane fluidity. It helps to move that. Dr. Adebayo was talking about the amyloid peptides and all that. It helps to remove some of these lipid rafts, the formation of inflammatory mediators and regulators. And one of it that I love to talk about is that the DHA reduces the activity of an enzyme called capsid. So this is an enzyme that actually involved in progressing brain cell death in people with Alzheimer's disease. So, and this is one of the very major importance of DHA in management or in supporting people with dementia or memory loss. Now, if you remember in one of the slides of Dr. Adebayo, mentioned the issue of amyloid peptide formation that now clogged, that has its fragment clogged around the brain neurons. And this is actually reduced through DHA. DHA reduce that accumulation, and that accumulation, when it's reduced, if you look at it, it also helps to reduce or slow down the progression of somebody coming down with dementia. Now, another important vitamins, as mentioned by both if you look at the research, and you've also heard it from Dr. Adebayo, is vitamin B12. Now, vitamin B12 is actually found to be very, very severe in low. It's very, very deficient in the geriatric age. In people that are aged, we've discovered that vitamin B12 is very, very deficient in them. And vitamin B12 also it has been proven to have positive impact on mood symptoms and cognitive and psychiatric mood symptoms. So imagine what Dr. Adebayo says, a lawyer or a retired lawyer going to a shopping mall to pick things they can actually buy and like stealing it down. So we've discovered that some of the things, also these things can be linked to vitamin B12 deficiency. So if we've discovered that there's a vitamin B12 deficiency, that invariably lets us to know that if this geriatric age group have intake of vitamin B12, it will help their brain, and it also help them to delay the issue of dementia, and also will help their mood symptoms. Now, there's a point here that outside the issue of memory, vitamin B12 remains an important part of a healthy diet. So generally, whether there is an elderly person that is already suffering from vitamin B12 deficiency, or there is a memory loss issue or not, vitamin B12 play a vital role in our general healthy living. And so when it is deficient, it's actually expected for it to be filled. Now, another minerals I would like to talk about is the phosphatidylserine fatty acid. Now, this also helps protect the brain cells. It helps in keeping their mind and memory sharp. Now, don't forget that one of the symptoms of dementia is forgetfulness, not forgetting when they drop this and that. I can relate this one to my grandma before she passed on. You give grandma or this and that, and like Dr. Adebayo said, some of them, because of our knowledge, we detest them. We are not exactly happy with them. We feel that all these age group, all these are old senior citizens love causing trouble. You know, you see them that some of them, they even wait for you to take basic decisions. Now, these cognitive abilities, it has shown that when they have phosphatidylserine, it helps them to improve their cognitive abilities and behaviors. You know, there was a particular research, as you can see on my screen, in 2015, and that shows that if you combine phosphatidylserine, omega-3 fatty acid together, there is a positive impact. And especially you can see it even outside memory loss. It also helps people with depression to improve. Don't forget that Dr. Adebayo mentioned the issue of pseudo dementia as a result of depression. When people feel that people that have depression end up with dementia, and even though they are two different things. Now, and I would like to talk about another herb, which is the ginkgo biloba. This is so popular, everybody knows about it. It has proven over the years that it helps to improve blood flow in the small vessels towards the brain. It helps to improve blood flow towards the brain. And this also helps in thinking, social behavior, and all of this, especially to perform daily activities. Now, if you look at all these vitamins, all these minerals, and these particular herbs that I've mentioned, they are what make up the Ephamol active memory capsule. Now, so there is Ephamol active memory capsule. Don't forget, going back to Dr. Adebayo's presentation, one of the places that we can come and play a major role is awareness. Dr. Adebayo mentioned that, and also to slow down the rate at which people get down with dementia. The truth is, age is irreversible. People will grow old. We want them to grow old. We are praying for them to grow. And like Dr. Adebayo said, that shows that very soon we are going to be having over 132 million people suffering with dementia. Now, I can tell you that for every person that have dementia, there is somebody by the side that is depressed as a result of the burden of taking care. So I think it is a major work for us to play a major role in prevention. Now, that brings us to the fact that if you look at Ephamol active memory, it's a mixture of all the necessary active ingredients that has been mentioned, supplements that have been mentioned. It is not one for the other. You can see I've mentioned the issue of the DHA, which is an important building block in the brain transmitting messages. I've mentioned the issue of the phosphatidylserine, which is very important for our nerve function. I've mentioned the issue of vitamin B12, folic acid, and ginkgo biloba. Now, Ephamol active memory has a combination, a blend, a proper blend of all of these important vitamins and minerals in order to help people, both people that have not gotten to that stage of dementia to slow it down, and people that are there to also help them improve the issue of dementia. Now, let's talk about just 1 or 2 minutes, why active memory. Now, it is not enough. There's a particular research when I was having a discussion with Famlawa a few days ago, that it is not just about omega-3 fatty acid. It's not all about, fish oil. There's fish oil everywhere. And research has shown that some of the fish oil also comes contaminated. Not all the fish oil are healthy. In the name of looking for something to help your patient, we shouldn't also give them something that is going to be dangerous to their body. Some of the fish oil we see on the market has environmental toxins. But when it comes to Ephamol active memory, over 40 years, FMO has been presenting pure, very pure omega-3 fatty acid. Now, what makes it pure? Like you see in my screen, we make use of the whole fish and not the liver oils, the whole fish oil, which is the naturally lower in environmental toxins. Now, they move from there to what we call gentle extraction. It is not, they are very careful to ensure that they get us a purified oil with 3 molecular distillation steps. This thing is very important for us to know that the oil we are giving is highly very important. Now we talk about it is in the triglyceride form. It is not enough to take omega-3 fatty acid. What is the form that people are taking? Now, apart from that, our oil is tested to ensure it is free from environmental contaminants and it contains DHA and it is stated to the expiry date. Now, if you look at FMO product, I know some of us have been selling FMO product or not, you can see that we are always proud to put it in boldly in front of our product that we are the most researched organization when it comes to essential fatty acid. And apart from that, this product is NAFDAC registered, as you can see. Now, let me quickly say this. If you look at our product now, like I said, I was in a conversation with Lawal a few days ago, and she was telling me that if you look at down on my slide under the 2 capsules per day with food and drink, it says that what any dose that is less than 400 milligrams of omega-3 fatty acid does not work. Why? Because a lot of the omega-3 fatty acid gets oxidized in the liver. So it is only a tiny little fraction that gets to the brain. And most times, if you take omega-3 fatty acid that is less than 400 milligrams per dose, that particular dosage is lost. Now, if you look at FMO active memory, just intake of 2 capsules, look at the nutritional information by the side. That offers you 1,000 milligrams of omega-3 fatty acid, which means that there is a significant, let's even assume the whole 400 milligrams end up in the liver, you have 600 milligrams that is getting down to the brain. And that is exactly where this thing is being needed. And that same 600 milligrams has over 500 milligrams DHA, 150 milligrams of EPA. That these are wonderful volume that can help the brain to retain its healthy position. Now we've talked about the today, we've talked about the vitamin B12, and all of this nutritional intake is what you can see. Now, another thing I want us to see is that our omega-3 fatty acid is free from dietary ingredients. It's free from yeast, sugar, and artificial flavors. Some of the products in the market have some of these contaminants as part of the makeup. Now, I've told us FMO is the international leader when it comes to essential fatty acid. Over 40 years of experience. We offer you good fatty acid, omega-3 plus 6 and all that, even Primos oil. And we are specialized in scientific research. I've mentioned that if you go online, you see a lot of research from FMO. Now, these are other products. I know this product is popular to a lot of us, and you can testify to the efficiency and the efficacy of this product. Talking about FMO Evening Primos oil, it is from the same manufacturer. This is, like I said, and even our FMO EPO has 33% retail seed oil compares to any other brand in the market. Apart from that, we're talking about the FLX brain formulas. We're talking about the one for the elderly. We also have FMO brain formula that can help the younger generation as a wonderful brain performance. Like we said, DHA is the most abundant omega-3 fatty acid in the brain. And from age 3 upward, when the brain is developing, it's always excellent for us to have a product or supplement that can help the brain develop very well. These things are very important. And this omega-3 fatty acid, 3 plus 6 fatty acid for children, both in liquid and capsule form, has been clinically tested to confirm effect of learning abilities. Now, this is not just English. We have a pharmacy that have been recommending a omega-3 FLS brain formula for a particular child that was traumatized when the baby was young, and over 3 years, the baby have not started talking, and the baby, but after taking Omega FLX brain formula for like 3 months, at least the baby have mentioned the first mama. We are very excited. It's a product that is doing very well in the market. And like I said, lastly, we can see all of this product from the children down to the teenagers, because like I said, the FMO brain formula liquid is for children from 3 years plus. Then we have the capsule for the adults, like from 5 years down to 40 something, 39 years. And once you are 40, I think you should do a birthday gift to yourself by start taking FMO active memory. Now, still look at it. We are very proud to tell you the word FMO is actually come from essential fatty acid, and we are very proud to tell you that all our omega-3 fatty acid and every product from FMO are free from all harmful pollutants. Now, if you look at this kind of product, you should know that it has to be a reputable organization that can market that product, and that is New White Pharmaceuticals. We are the official distributor of FMO ranges in Nigeria. So talking about the active memory and all that, we are the official distributor. Now, one thing is this, let's go back to it. Like I said, the most important for me is that there is a lot of burden in managing dementia. I think it is a clarion call for us to ensure that we slow down the rate at which people come down with dementia, especially in Nigeria. Thank you very much, everybody.
All right, thank you very much, Mr. Ebenezer Olayinka from New Heights Pharmaceuticals. That was a beautiful presentation as usual. Okay, now we will be going to our own pharmacist, Folashade Lawal, who will be bringing it home to us as pharmacists, whether we find ourselves in the community or in the hospital. Our roles, what we need to do, how we can best support our patients, and of course, some experiential learning. And so without much ado, ladies and gentlemen, I'd like to bring up the one we call CC of Pharm Alliance, the clinical coordinator. Need I say she's a double CC because she started off as a class captain, now clinical coordinator. And on all matters clinical, we defer to her. Ladies and gentlemen, without much ado, join me in welcoming our own pharmacist, Folashade Lawal, as she brings up the community pharmacist perspective to the management of memory loss, dementia, and Alzheimer's disease. Over to you, ma'am. No, I can't hear you. Yes, we can hear you.
Okay, that's fine. Good afternoon, everyone. Distinguished colleagues, erudite lecturer, and members of New Heights team. I'm highly delighted to take us through, to place more emphasis on our role. You will agree with me that Dr. Adebayo did a fantastic job. In fact, he has delivered everything. So I will just share some experiences with us, and we will reposition ourselves as community pharmacists, because there's a lot for us to do, especially with this very emotional problem, because I could see all of us getting into the emotion of this condition. So let me start by sharing a case study. It happened some years ago. Madam B drove down to the pharmacy to get some medications, and she returned home only to find out that she had forgotten her car in the pharmacy car park. So she came back, she was worried, and if you were the pharmacist, how would you help her? As you think through, let's briefly rush through the slides. I have no intention to take too much of our time. And like I said, And like we all know, Dr. Adebayo has done a lot of work. So I will just focus on those areas that complement what he has done. So this is my outline. Then brief definition of memory loss. He has dealt with it extensively. He has talked a lot about this, so I won't bore us with this. I just want us to look at peculiarities of the community pharmacists. Let's remind ourselves that we are usually the first point of call. We are readily accessible. Patients that are ill, patients that are apparently well, patients that are well, they all come to us. Yeah, we are trusted healthcare professionals. We are known within our community. We render a lot of services, including pharmaceutical care, disease prevention or awareness. We are engaged in strong collaborative practice. We are highly trained and we are patient focused. So let's look at our roles in this big problem, memory loss. We can't help to assess patients for memory loss and early signs of dementia because, like doctor told us, dementia is a long-term illness. It takes time to develop. And at the early stages, most of the time it is missed. And that is the sign that more often than not, we see these patients. So we can help to assess these patients at this early stage, pick them up for referral, get them referred when necessary. And if it's just simple memory loss, we can help them with supplements that will be of help to them. Then we can also engage in a lot of public enlightenment on memory loss. Sadly, in time past, I'm sure it's still happening, a lot of people have been, elders have been abused because of their dementia states. So we can come in there strongly, let the public understand what this memory loss or dementia is all about, so that we can save our elders the embarrassment and the abuse. We can also provide nutritional support. Ebenezer has done a great job there, telling us about supplements that may be of help. We can help to identify patients that are at risk of developing dementia and work with them to prevent it. We offer a lot of pharmaceutical care services. We see these elderly patients when they're still their memory has not started deteriorating. And by the time we are counseling them, we are tracking, we are talking with them, we can pick out one or two things that may suggest to us that this patient is likely to have probably a memory, is this a classic memory loss or is just a brief memory loss, whatever it is, we can work with them to develop, to find them out. I know a few of my patients. I recall not too long ago, there was a particular patient, diabetic, hypertensive, and by the time I was interacting with her, I could pick the flaws. And then the next time she came, I saw those flaws were becoming more glaring. So I had to call her daughter to say, look, it's like your mom is having problem with memory. Please, please, please take care of her. And interestingly, the daughter too was already noticing, but she didn't want to, because of the stigma. Many times they don't want to own up or say anything. So I helped her to get her mother, get doctor's attention and all that. We can help in identifying early stages of dementia, like I said, and then referring appropriately. We are not going to diagnose. The diagnosis is for the consultants, the doctors, but we can pick them up and refer. Then we can provide support for dementia patients, like Dr. Adebayo told us, they need a lot of support, and that support can come in different forms. We can support them with their medications. We can support them by educating them on way of life. We can even have clubs for them. Thank God for COVID. It opened our eyes to so many other things that we can do. So we can have clubs where these elderly people are, or before they even go into this stage of dementia, we can start preparing people for old age. If we have clubs that address their health concerns, and they're getting themselves prepared and ready for what old age brings. We can provide pharmaceutical services for patients with dementia. You will agree with me, they usually have a lot of medical challenges. So there are so many medications, and we should be there doing medication use review. How many of these drug therapy problems can we identify? How can we help them to make the most or to optimize their medications? Those are the areas that we can come in very strongly. And there's a lot of work there. Even during this lockdown, I had to visit an elderly patient because she was seeing so many consultants, and everybody kept giving their own medication. And by the time I was seeing her, this woman was on 3 different brands of azithromycin that were given to her in 3 different hospitals. And one was 250 milligrams, one was 2 others were 500 milligrams. They had different trade names, so she would just have taken everything. We can help in identifying potential memory loss inducers, like those drugs that might induce memory loss. And is there anything that we can do about them? Is there any way that we can intervene? We can help our patients also to adhere to therapy. Quite a number of them have difficulties at certain stages taking their medications, probably because of their condition. Some of them might just refuse to swallow tablets, and we can formulate for those ones that can be formulated. I've had quite a number of referrals along that line. They will refer patients is not agreeing to swallow their capsule or tablets or whatever. What do we do? There are some capsules that you cannot formulate into syrup, but they can be opened at the point of administration, like amantadine. We had this patient, we had to advise them what to do with those medications. So we can give a lot of support to our patients in terms of their drug therapy. And some of them might, I recall one particular patient, she would just not take her medications unless I said so. And sometimes I would have to go to her house to make her take her medications. So by then she was already into dementia anyway. So she just once in a while in and out, but somehow she was always able to recognize me. So she would ask that they sent for me, and I would go there. She was hypertensive and with dyslipidemia and all other conditions too. So she needed to take her medication. Sometimes her BP would be high, and they would come looking for me. Mama has refused to take her BP medications. Mrs. Lawa, she's looking for you. And then I would go there and cajole her. Sometimes she would display some emotions. She would smile, she would laugh, she would cry in between, and then they laugh together and empathize with her. But at the end of the day, I always succeeded in helping her, making her take her medication until this terrible lockdown. When this lockdown came and I could not visit at that critical period, this I found out that Mama developed a stroke. Thank God it wasn't so serious and she's recovering, but it's because she refused to take her medication. So there's a lot of influence that we wield as community pharmacists, because we've been with them for years in that community. They know us, they trust us. We can help our patients organize their pills using pill boxes to promote adherence and prevent drug paroxysm. Much as some of them skip medication, some of them also overdose themselves. Sometimes they're taking that medication and they are forgetting. They just remember, oh, I'm supposed to take this, and then they go and take another dose. I had, it was also another, interesting case because of the intervention that we made. She was already also into this memory loss, and one of the days she also had she had arthritis, so she was on medications for arthritis. She had taken her drug, and then she saw something that looked like her drug again, and she took it. Unfortunately, that was doxycycline, our husband's remedy for prostate. So she took 2 tablets of 4 milligrams. And it's because I met her. I was just, it was just an intervention. It was just a divine arrangement that day because I didn't have to. But she came around and I was like, Mama, are you doing this and that? And then she brought it out and showed me that she just took 2 tablets of this. I said, Mama, but this is not your own medication. And then we had to call in the doctor. We co-managed. We looked out for signs of toxicity. Luckily, by God's grace, she put through. Interestingly, she had rebound high blood pressure. She was not hypertensive before. Her blood pressure first went up. Interestingly, then it came down to normal again. So we can help all of these patients in different ways. And we can also collaborate with other healthcare professionals in the management of the patients. By the time they know the contributions that we make are invaluable, they will work with us. When I went for Commonwealth Fellowship in the UK, I noticed that they had clubs called the Adult Abuse Clubs. And these clubs address some of these issues. So we can set up clubs like that, and through those clubs, NGOs help our elderly patients. Dr. Adebayo saw the need for their medications to be subsidized, and these clubs can address different things, especially because in that age, many people misunderstand them, they stigmatize them, they keep away from them. I know one family I had to intervene. The woman was always accusing other members of the family of stealing her things when nobody was stealing her things, but it was part of her medical condition, and they didn't understand. They just thought Mama was becoming unfriendly. So it took intervention to help them to understand that, look, this is part of this Mama's illness, and she meant no harm, and this is a way to go about it. So we can work with other healthcare professionals. We can mount up advocacies. Yeah, drugs that may cause memory loss, just to refresh our memory. Like I said, I had prepared so many slides, but Dr. Adebayo has said so much and I don't want to bore us, so I'm trying to skip through. But it's good for us to know that some of these drugs can cause memory loss. And interestingly, I found out somewhere in one of the references that for those who don't have coronary heart disease and need statins, because statins too may impair memory, it might be okay to replace their statins with B12 1000 microgram, folic acid 800 microgram, B6 200 micrograms. So we can suggest that with their doctor and see how it goes with them. Then we can also substitute their benzodiazepines with melatonin. I'm sure when we walk through this, we might be able to find some other substitutes. I also had an elderly patient that was placed on anticholinergics and for incontinence, and she reacted badly to it. So I stepped in, I calculated the HCB, I saw that it was high. Then I went to search for one with very low HCB risk. And I discussed with the consultant to say, your patient will benefit better from this because of her age. And he said, okay, go ahead, let's use that. And Mama is doing fine on that one. She doesn't have problems. So there's so many ways that you can come in. This is one of the instruments to assess dementia. It's simple enough for us to use. We might need to get some training so that we use them very appropriately, because it might be misinterpreted, especially in not too literate patients. So, but these are simple things that we can use, and then we know when to refer and where to refer them to. Dr. Adebayo talked a lot about drug treatment. I think one of the things that I just want to add to acetylcholinesterase inhibitors is that sometimes the patients might have some side effects like nausea, vomiting, loss of appetite, but for many cases, this is all after 2 weeks. So we can just encourage them and help them to bear through the 2 weeks. And then they are able to go on with their medications. Ebenezer has said a lot about supplements. I went to research to find those that have scientific backings for their use. And omega-3 is said to help build cell membranes, and they also may have anti-inflammatory property. You know, these supplements are not too researched into like that, but then there are abundant researches to support their use. B6, B9, B12 may help the brain through the breakdown of homocysteine. Vitamin D may also help in the prevention and treatment of dementia. So let's go back to Madam B case study. Madam B drove down to the pharmacy to get some medications. She turned home only to find out she had forgotten her car in the pharmacy car park. She was worried about her condition. She asked to see the pharmacist. If you were the pharmacist, how would you help her? Do you have anybody that wants to try that out? Hello, can you hear me? Maybe I'm on my own.
We can hear you, ma'am.
Okay, thank you. Please, is there anybody that wants to try that case study? If you were the pharmacist, how would you help her?
People will only be able to type in, they may not be able to talk because it's the webinar form. So
okay.
Yes.
Okay, let me save our time then. You see, it's good to find out from Madam B what really happened. Is this a one-off thing? And then we'll start by looking at the age of Madam B. Madam B in this case was a young woman. She was about 45. So she was less likely to have dementia at that age. I know it's possible, but it wasn't, I mean, with her age, our risk profile was not so high. So by the time I interacted with Madam B, I found out that she had she was stressed up. And because she lived near, she was used to walking down to the pharmacy to just get a drug and then walking back home. This particular time, she was coming from somewhere and she just parked. There were many cars outside. She dropped the key in her bag. She walked in, bought what she would buy, and then she just strode back home her usual way. So for her, it was like a one-off thing. She didn't have a repeat of that. So for me, I wouldn't say that she had a critical memory loss problem. But Madam B too, now we have to step in to see how we could help her with her stress, what advice to offer her, and she could also benefit with some supplements that will help her. So basically that is what transpired between us and Madam B. Like I said earlier, we're all still learning on this point. But I want to leave us with a few take-home points. It's normal to forget things once in a while, very normal. Aging does not have to cause serious memory loss, no. You can, some people age without losing their memory to the extent to be tagged dementia. Normal aging doesn't cause traumatic memory loss. Early detection and prompt intervention helps people with dementia and members of their families to receive timely practical information, advice, support, and alleviate anxiety. Very true. The pharmacist's role in prevention and management of dementia is invaluable. We see these patients before they get to the level of diagnosis, because sometimes it's over years before it becomes a big deal. We can be a dementia preventer and advocate for dementia patients. There's paucity of evidence for the use of supplements, except fish oil, vitamin D, and the B vitamins in protecting the brain. So I want to conclude by saying that, sorry, let me bring this into slideshow. Our roles as community pharmacists keep expanding with more focus on disease prevention. We as community pharmacists have invaluable roles to play in the management of memory loss, spanning prevention, assessment, appropriate referral, drug therapy support, and follow-up. Thank you for your time. My references are there. I want to appreciate God for this opportunity. I thank management of New Heights for giving me the opportunity to share a few of my experiences on this matter with us. And thank you to all my distinguished colleagues for logging on to this program. Thank you, and God bless you all.
All right, my CC, thank you very much for pulling this off. Even though you are not in town, you still are committed to this course, and you have done us proud as usual. Okay, having gone through the 3 sessions we have, first with Dr. Adebayo, then with Ebenezer Olainka, and then our own CC of Farm Alliance. We are now taking the questions as we wrap up today's program. And so I have 11 questions here in the question section. I see that a number of them have been answered. So let me just take, Dr. Adebayo, could you please come back on? Okay, good. I see.
Yes, I'm with you.
Oh, good, sir. All right, so someone says here, how does low education levels contribute to the risk of Alzheimer's disease?
Education, we talked about the causes of dementia as multifactorial, multifactors. And we talk about genetics. We also talked about environmental factors. Education is key when it comes to issue of knowledge. And of course, right application of knowledge is wisdom, but you must have knowledge. So when you have knowledge, it will help you to adopt, to know the lifestyle you should key into. Of course, we have people who have education and yet they still live their lives anyhow, but education matters a lot because the emphasis here is that, yeah, people, more of awareness. It's easier to create awareness for people who have some level of education than those who don't have any level of education. So it's on that basis that we feel that, you know, when you are aware of a thing, when you have knowledge, appropriate knowledge, you will be able to avoid the pitfalls that can push you into problems. Yeah, you can have PhD holders here having a stroke, yes, but having knowledge will also help you to know your limits, to know what you're supposed to do, to know the relevance, to know the importance. When an individual begins to have issues, begin to know what to do rather than to pass everything as spiritual or as enemy concepts all the time. So those who have done studies here and there felt that it's one of those factors that can help both in prevention and the management of the dementia. So that's about education. Can I answer some of the questions?
No. Okay, and sir?
Yes, someone wanted to know about. Can I go ahead?
Go ahead.
Yeah, whether herbal medications, traditional treatments, and all that can also help in dementia. Well, unfortunately, I'm not. Not alternative medical practitioner. So I don't prescribe herbal or traditional. I will not be able to say from literature that traditional or herbal medications helped. People also want to know whether Alzheimer's dementia and dementias are hereditary. Well, some, a lot of them are hereditary in nature, you know, because hereditary is one of those risk factors we talk about. But of course, you can see some isolated cases of people coming down with dementia, not as a result of hereditary. That's about that. Then the prevalence or whatever in Nigeria, a lot of studies have been done about the dementia project in UCH, eraded all these studies some years back, but we can say likely about 4.9% or thereabout, around that, are cases of dementia among from the studies that have been done. And of course, females are more affected than males. Mind diets, can it be an alternative to medications? No. Mind diets, we need that more for prevention first. And of course, for those who have it, yes, it can also help to a large extent, but it doesn't mean that mind diets will be an alternative to medication. When do we start giving those medications? I talked about it, mild to moderate, yeah, the cholinesterase inhibitors, but moderate to severe, yes, we have to consider the NMDA's antagonist receptor, especially memantine. But a mind diet is useful, but it doesn't mean that it's an alternative to medication. Are there some other questions? Cholesterol leading to memory loss and all that. Well, high cholesterol, we know is not good for the cardiovascular system, and it's also not good for the brain. You've had a lot of people who have high cholesterol, and they eventually come down with stroke, not even because of high blood pressure. Cholesterol hyperlipidemia is not good. So it can lead to stroke. And one of the fallouts of multi-infarcts areas in the brain is dementia. Later on, dementia can lead to dementia. So that's the connection. That's the connection. Are there other questions that I have not read or that have not explained? High cholesterol leading to delirium. We all know that metabolic disorders can give rise to delirium. Delirium is an acute condition that individual has impairments in the level of consciousness, fluctuation in level of consciousness. Why dementia is more chronic, it's more of a chronic condition. Why delirium is an acute condition as a result of some underlying medical problems. I hope I'm able to shed more light on that. Are there questions, other questions that
I'm sure that you attended to this one that says, can omega-3 improve memory loss, and how often should it be taken?
Yeah, I said research has shown that it can be helpful. I should be taking, I think you pharmacists will be able to tell us more about that. Let me allow the learned pharmacists in the house to tell us.
Okay.
But here we advocate that our patients should take it daily. That's what we advocate in our clinic, that patients should take that daily. But not necessarily indefinitely, not forever, no. If it helps, fine. If it doesn't help, we don't really have to be wasting patients' money on medication that or treatment that does not really add value. If we feel that it doesn't add value to the patient, even the normal the donepezil stuff, rivastigmine and all that, if it gets to a stage that we are not seeing any improvement in the patient, we might decide not to continue with that, or continue supportive therapy for the caregivers on what to do to help such patients.
Okay, okay, let me see. Somebody has dropped a question here for Folashade. The milligrams of the Bs you recommended instead of statins, is there any single formulation that takes care of that to avoid multiple swallowing?
I have not looked out for one, so I cannot immediately tell you there's one. But I'm sure you will have the slides, so we can look at them. They may exist not in a combination, because I know I had to be on B12 for a while, and it was prescribed for me 500 micrograms. I mean 5,000 micrograms. So these doses are variable. I also want to comment a little bit on the fish oil. Fish oil might be helpful. It's very dicey with fish oil. Yes, it might be helpful. At times, these items look very innocent. But there are some conditions that we have to exercise a little bit of care. I recall, I'll give this because it happened to me many years ago, about over 10 years now. My father just, one of the days, we just found out that he was not saying things properly anymore. He was incoherent. Just suddenly, up to now I speak, my father knows everybody's phone number by head. Does not forget your birthday is the one that reminds everybody. It was around my birthday. He didn't even remember my birthday. So I got naturally worried. The only condition I had was high blood pressure, but it was on other supplements that were given and all that because of his high cholesterol. So at the end of the day, we found out that we have worked this for days. It was traumatic, it was terrible. I thought I was losing him. At the end of the day, we found out that he had subdural hematoma. The surgery was done, and by the next day, all his memory came back. Everything just reversed. But where I'm going is this: up to now, we don't give him anything that can thin out blood because of that experience. And you know, fish-oil might also be a blood thinner. So we should also exercise some care, some caution is necessary. We should not just bombard our patients with supplements. We should try and find out which ones will really benefit them. And where in doubt, please let's refer. It's good to know our patients' history properly. I also want to quickly take advantage of this slot you have given me to talk to appreciate Pharmacist Adebisi Ajibade, manager who is standing there for me just in case, because I traveled and I wasn't sure of network. So she's there standing for me in case I was unable to make this. Thank you, Pharmacist Adebisi. God bless you.
Thank you, Ma. And your lieutenant, you're very strong lieutenant.
Very strong, my powerful lieutenant.
Yeah. All right, let me call on Ebenezer now to take the few questions that have to do with FLX. I'm sure you can see the questions. You want to take them now?
Okay, yes, sir. One of the questions talk about the issue of price, and I can see questions around duration. Like it has been said, we recommend that for new users to first of all go for like 24 weeks. So like Dr. Adebayo said, like after 24 weeks, you can actually check if there is impact, improvement, and all that, and we can space it for them to continue. Now, talking about the issue of price, the FLX active memory, a pack of 30 capsules is actually 5,150 naira per pack. But like Dr. Adebayo has advocated, and something we see for everyone that participated, management has also approved a discount for people that will be buying right now, and we hope the discount will get to your patients. For anybody that placed their order now, we are going to be actually having a 5% discount. So that will be going for like 4,900 instead of having it for 5,150 naira per pack. That is for the issue of price. And is there any other question, Mr. Shino, that I'm missing, sir?
I think that's large. Most of them have been answered on the background. Dr. Adebayo, somebody is asking, please put your number there in the chat section so that in case I want to reach out to you. Ebenezer.
Okay, I'll do that right away.
Are there withdrawal symptoms if medications are stopped abruptly, if there is value added to, maybe, I think if there's value added to patients, I'm not sure what that is, but this is the question typed, I hope it's correct. Are there withdrawal symptoms if medications are stopped abruptly, if there is value added to the patients?
Whether there are withdrawal
symptoms.
Withdrawal symptoms?
Patient stops taking his medications. Are you aware of any?
I'm not. Okay. No. No,
okay.
In my practice, I'm not aware of that.
Okay, Mrs. Lawal, anything from your end?
Well, withdrawal symptoms can be from any medication that is prone to that. So this is just a blanket question. It depends on the drug we are looking at.
Okay.
So there are some drugs that might have withdrawal syndrome. There are some drugs that don't have withdrawal syndrome. So except we know the drugs are.
Okay, I believe we have done justice to all the questions asked. Once again, I want to thank everybody for staying with us on this 2-hour webinar. We thank you all for keeping faith with the project. The numbers are there. If you want to place your orders to enjoy the discounts that New Heights is providing for all those who are participating in this webinar. Stay tuned. You will be hearing from us very shortly when we bring up our next webinar on the Farm Academy platform. Until then, do have a lovely day ahead. God bless you all. Thank you very much. Please note the slides and the webinar recording will be shared in a few hours or maximum tomorrow. You'll get to see your emails. Thank you.
This population
We have 154.
okay.
Thank you.
Thank you, sir.
We don't know that person.
Not yet.